derivation of blood flow is how we measure blood pressure. So this is going to help kind of tie in our lab today. Well, we want to make sure that we have optimal flow through the heart, so we can measure that due to its relationship to pressure. And we're going to be able to measure our systolic pressure and our diastolic pressure to be able to derive that indirectly. And I'm starting on page 14, last slide. Oh, 14, last slide. And as we've talked about the normal capillary function. We've talked about the movement of fluids, as you know. Filtration taking place on the arterial side, reabsorption taking place on the venous side of our capillary bed. Now we know how it's supposed to work. Now let's start to talk about how we can adjust in order to adjust our blood pressures as well as adjust blood flow and all the mechanisms in our cardiovascular system to in order for autonomic regulation. How do we speed things up? How do we slow things down? And with that, we need to talk about the feedback system, all things that are going to be, all the sensory information that's going to be led back into the central nervous system in order for us to help regulate the cardiovascular system. We'll talk about the renal pathways, the kidney function in order to maintain normal blood pressure. And then we'll talk about the endocrine functions as well, what hormones are going to be released in order to maintain regular function. And lastly, we'll talk about vascular autoregulation. So these are things that are geared to make sure that adequate blood flow to our critical organs, or to all organs, all functional organs, are maintained. So with that, this is going to start to revisit some of the things that we've already seen before. Looking at the top of page 15, our autonomic nervous system. We mentioned earlier that central nervous system does provide autonomic regulation of the cardiovascular system as well as the vessels. So we saw with sympathetic pathways, we saw an increase in heart rate, the intrinsic heart rate, as our sympathetic pathways as well as our parasympathetic pathways led directly to the SA node and the AV node. Okay? And that would drive up heart rate, which is one part of our cardiac output. Okay? The second part would be the sympathetic pathways that lead to the ventricular muscle mass, and the ventricular muscle, leading to the ventricular muscle mass to increase the contractility of the heart muscle. And the last thing that we were able to see was the effect of the sympathetic nervous system on venoconstriction. So constrict the veins, squeeze that blood out of the veins, get that to return back to the heart, and that's going to increase preload. By increasing preload, that's going to increase our stroke volume, how much blood is pumped out. If we get more blood into the heart, we can pump more blood out per heartbeat. So that's an increase on stroke volume. So those are our mechanisms in place, and we're going to be able to receive input from all of those receptors that we talked about in our sensory lecture. Proprioception, our baroreceptors, as well as our chemoreceptors. Again, proprioceptors were our kinesthetic receptors. They tell us a state of what we're doing at the time. Are we moving around? Are our joints moving? The stretch receptors, all of that. Okay? Is our head moving around when we can measure static equilibrium and dynamic equilibrium? We'll look at our baroreceptors. And the baroreceptors we mentioned, as well as our chemoreceptors, are located in the carotid arch, as well as, carotid sinus, as well as our aortic arch. And that ties into our next slide over on the middle slide on page 15. Lastly, you're also going to see minor baroreceptors that are located in the kidneys as well as the atrial walls, which we'll talk about in the next slides over when we get to renal autoregulation and hormonal, heart rate autoregulation. So we'll talk about those. So looking at our baroreceptors, looking at our baroreceptor reflexes, you'll see that the reflex here, the carotid sinus reflex, basically will normalize blood pressure in the brain. So the carotid sinus is going to be important because this is where we want to maintain normal blood pressure to the brain. Obviously, if we don't have enough blood flow to the brain tissues, that's going to start to affect autonomic regulation. Central nervous system is everything. It is our central control for all of the systems. So in any mechanism where we start to see a decrease in blood pressure, what we're going to see is with a decrease in blood pressure, that means our baroreceptors aren't firing as well as they're supposed to. So the less firing of our baroreceptors results in the cardiovascular center firing more. And that's all due to sympathetic pathways that are going to increase sympathetic output. So we increase sympathetic output, at the same time we want to decrease vagal tone, meaning we want to decrease the amount of parasympathetic output. So one of the quiz questions, I believe, I don't remember if it was a quiz question, but if you were to raise your heart rate, let's say you start running, you want to raise your heart rate, we decrease parasympathetic output, so we go from 70 beats per minute resting heart rate, brings us back up to the intrinsic firing rate of the SA node at 100 beats per minute. And then if we want to beat faster, then we increase sympathetic output. And with that, that's going to be the effect specifically on the heart, where we see increased heart rate and decreased stroke volume with the same mechanism that I just described. And then we'll be looking at the vessels. What vessels? The venous blood reserve, or return. This was venoconstriction. Squeeze the veins, get more blood flowing back, as well as vasomotor tone in the arterioles. So what do I mean by vasomotor tone? That's basically vasodilation in our involved organs, namely leading to that to the brain, skeletal muscle, heart, lungs, things that are all part of the sympathetic response. Things that are not going to be critical, gastrointestinal tract, kidneys, so forth. So we'll decrease. Therefore, we'll vasoconstrict those vessels leading up to those organs in order to redirect blood to our critical organs. So that redirection of blood through vasodilation and vasoconstriction is what we call shunting. And we'll explore that concept more in our respiratory lecture, actually towards the end of this lecture. And then what happens with that? So employ those mechanisms where we increase sympathetic output and decrease parasympathetic output, both on the heart as well as the vessels, is going to be the effect of increasing blood pressure. So what starts off as a decrease in blood pressure, as received by the carotid baroreceptors, leads to an increase in blood pressure. Okay. So that, in effect, is another form of negative feedback, how we maintain homeostasis in blood pressure. So leading to that, why is it important to have normal blood pressure? As I mentioned, we want to make sure that blood pressure is normal within the capillaries, because this is our exchange. These are our exchange vessels. These are the ones that are delivering all of our necessary glucose, delivering our gases through those three same mechanisms that we talked about: bulk flow, which is the movement of fluid; transcytosis, which is the movement through the endothelium; and then lastly, through diffusion. So those mechanisms are what we need in order to maintain pressure. If we see a decrease in pressure, we see fluid moving back in. We see recall of fluids. We don't want that. If we see too much, then we get more fluid in cases of hypertension, we get more fluid or more pressure in the capillaries. And that's going to lead to more fluid out in the interstitial fluid, which will result in edema. So we want to make sure that that is in place. So with that, we're going to take a look at page 16, the chemoreceptor reflexes. So with that, I've been talking about blood pressure. We want to see, are there any other chemical signals that the body can receive to tell us the state of our tissues? And that also involves our chemoreceptors. And we're back. So once again, while my computer's still trying to load, there we go. Chemoreceptor reflexes. So the same places where we have baroreceptors, namely our carotid bodies as well as our aortic bodies, have the same chemoreceptors that detect changes in our blood gases, namely our O2 and CO2. And it should make sense. If those bodies detect low oxygen, right, so O2 levels are starting to drop, that must mean that I'm not getting enough oxygen to the brain. Therefore, what should I do? Get the cardiovascular system to pump more, get more blood flowing to the brain. Okay? Let me give you an example that we already talked about. We talked about G-lock. G-lock was where we saw the loss of consciousness due to our jet fighters as they're flying up and they're exposed to high G-forces. That's pulling blood or decreasing blood pressure in the brain. And therefore, we're going to start to see hypoxia. And why did those people pass out? Well, it's due to low O2. So what happens in that case? Well, they should be able to raise blood pressure back up. Okay, that might be an extreme example. Let me give you another example. Orthostatic hypotension. Does anybody ever have the feeling of getting up real quickly and then you feel kind of dizzy? Yeah? I get that all the time. What happens? What do you guys notice? You notice your blood pressure go up? You just know your blood pressure goes up? You're like, oh man, my blood pressure's going up. No, that's not true. Well, I don't know if that's true. You know, if you can feel your blood pressure, good for you. But what you do notice is that your heart starts to beat faster. In fact, it's actually a fairly fast response. You might start to feel a little bit dizzy, but essentially your heart rate will go up. And why do we do that? Well, we're increasing cardiac output. Increased cardiac output, increased blood flow due to our O2 levels dipping a little bit, hence blood pressure decreasing. We want to make sure blood pressure is normal in order to make sure that fluids still move. Excess CO2. So looking at low O2 and excess CO2 in the case of high metabolism. So you've got, let's say in our systemic circulation, we've got low O2 and more CO2 building up due to our tissues being actively or cellularly metabolically active. So we're going through cellular respiration at a fast rate, we're churning out ATP, and therefore we're going to see a decrease in O2 as well as an increase in CO2. And also we will see increased acidosis, meaning more hydrogen ions being secreted from lactic acid. All the other byproducts of cellular respiration will start to see leak in. Those hydrogen ions can also be buffered, but any acidosis that's taking place, again, we need to ramp up cardiac output. So bring it up, and therefore to maintain homeostatic values, maintain normal blood pressure. So all of these you've seen already, again, looking at input to cardiovascular center, and then the outputs, whether the heart and then the blood vessels in order to maintain normal blood pressure. We'll also see in our respiratory lecture the effect of the sympathetic pathways. I've talked about trying to ramp up the cardiovascular system to increase the amount of O2 and get rid of CO2. By ramping up the cardiac output, we will see how we enhance gas exchange in the lung through sympathetic output. Vascular autoregulation, and the term over here is auto-regulate. So the term auto means automatic. It's not autonomic, where we have the central nervous system innervating the vascular beds, specifically the capillary tissues. This is the ability of a tissue to automatically do it on its own without any form of central nervous system stimulation whatsoever. So in these cases, what this is basically saying, again, we have arterial, we have our met-arterial that's leading into the capillary bed. We have the precapillary sphincters that are those little nozzles that are automatically regulated in order to increase blood flow or decrease blood flow. So in the cases where we want to increase blood flow, we have these precapillary sphincters that will respond to certain stimuli. And the stimuli on this case for physical change, what do I mean by physical change? Temperature. Temperature's a good one. Yes?
Yes, like I know one of the older slides said that the arterial is the capillary junction and then autonomic innervation.
The which ones?
The ones that are in the capillary junction?
Yeah.
But these do?
No. So that's what I mean by auto-regulation, meaning that there's no autonomic pathways that lead to this. Okay? There's no nerves that lead to these precapillary sphincters. These are the ways that these capillary beds regulate themselves. And that's what I'll talk about. So temperature. When we see an increase in temperature, that's going to open up those precapillary sphincters and deliver more blood flow to that capillary bed. And the term that I'll talk about again later on is what we call perfusion. Perfusion is the blood flow into a capillary bed or into a tissue. So this is specifically one tissue that we're looking at. We want to be able to increase blood flow through that area. Why temperature? Well, think about what happens through cellular respiration. We're producing ATP, we're producing energy, but a good amount of that energy is going to be used as heat, which was our second law of thermodynamics. We're going to produce heat at the same time we're producing ATP for our active tissues. The next thing also, again, trying to think about the converse, why would we apply cold to a certain tissue? That causes vasoconstriction, or specifically in our vessels, that will cause constriction of our capillary beds. If you have inflammation in that area and you want to decrease the amount of blood flow to that area, you put a cold pack on there, and that will close up those precapillary sphincters and therefore get blood to flow through without more flowing through. Vasodilators and vasoconstrictors. So these are going to be under the effect of other hormones. And the one that we talked about is nitric oxide, which is a potent vasodilator. That will come in and open up those vessels as well. Any other byproducts that come in, like lactate, will also open this up. So if you've got a bunch of lactate in that capillary bed, you've got your muscle tissues over here that are churning out lactate, that are diffusing out into the interstitial fluid. That will come in and also start to affect the precapillary sphincters to open them up. Again, bring more blood flow, therefore bring more oxygen, and rely less on anaerobic metabolism. Because you want to use that pyruvic acid and get that into the mitochondria, get enough oxygen into the mitochondria so you can start making more ATP per glucose molecule. So that makes it much more efficient. So this is the case. All the things that I've been describing are the cases of the systemic circuit, where you have a muscle tissue, and in response to low O2 or high CO2, will come in and dilate the precapillary sphincters. And that's only relevant for the systemic circuit, where vasodilation with low O2 to increase blood flow there. Now, the other system that we'll be looking at, the pulmonary circuit is different. When we look at the capillary beds within the lungs, we're going to be doing the exact opposite. So if there's not enough O2 in that area, the capillaries are going to want to close up, as opposed to opening up in our systemic circuit. They want to close up, because if there's not enough O2, that's not an area of the lung that has a lot of oxygen. It's not an oxygen-rich area. Therefore, it's a waste to bring blood through there to participate in gas exchange if there's not enough of an O2 gradient to pull O2 in. And that will make more sense when we talk about that in our respiratory lecture. So you'll see that this is a very different response: vasodilation with low O2 and pulmonary vasoconstriction with low O2. Again, really just the programming of these precapillary sphincters. Renal autoregulation. These are the pathways that we lead, again, all through the kidneys in order to maintain blood pressure. As we'll learn in our urinary lecture, we do have juxtaglomerular cells in the kidneys that will determine the amount of blood flow, again, related to blood pressure. So those are baroreceptors that are located in that area that determine the amount of blood pressure in that area. So this is going to employ the RAS system, renin-angiotensin-aldosterone system, which we talked about at the very end of our endocrine lecture. And in this process, remember, our stimuli, or our stimulus in this case, is decreased blood pressure. What we want to do is raise blood pressure. So any decrease in blood pressure, this system is going to be conserving water and conserving salts. Specifically, we want to conserve sodium. We want to not really so much conserve potassium. and we also want to conserve water. So again, we can just kind of briefly go over this because I know you guys have already seen this before. But the decrease in blood pressure results in renin release by the kidneys. And renin release is that enzyme that is going to convert angiotensin 1 into angiotensin 2. Renin is going to convert our angiotensinogen into angiotensin 1. So angiotensin 1 is going to make its way through the ACE enzyme, our angiotensin converting enzyme, will convert angiotensin 1 into angiotensin 2 in the lungs. Angiotensin 2 on its own is a vasoconstrictor. So it'll make its way to the vessels to constrict the vessels. What does constricting the vessels do? Should raise blood pressure back up. Take a vessel, squeeze it, raise blood pressure. So that's our way of raising blood pressure. The other effect is angiotensin 2, when it makes its way over to the adrenal cortex, gets converted into aldosterone. We see the secretion of aldosterone, which will work in our kidneys to do exactly that, raise sodium, decrease potassium, and raise water. So now what we're doing is we're constricting the vessels in response to low blood pressure. We constrict the vessels and we conserve water. We have less secretion of water in the kidneys. And that should effectively raise blood pressure back up. What questions do we have about that so far? Hormonal autoregulation. This we've already talked about. So epinephrine, norepinephrine. We've gone over that. That is sympathetic output. The antidiuretic hormone is a hormone that we haven't quite talked about. We did talk about its way, and again, antidiuretic hormone is the hormone that helps us conserve water. It's not related to sodium or potassium. It's strictly an antidiuretic. Stop us from peeing excess water. So in response to, again, dehydration or decreased blood volume, low blood pressure, we want to conserve water, and that will turn off our way of, that will enhance water reabsorption in the kidneys. The other thing that we also called ADH was vasopressin. That was the other name. So it also has a direct effect on the arteries to conserve them, or to constrict them. So where did ADH work on? Not only did it work on the vessels as vasopressin, so here this is our arterioles. So that was area number 1, where it works. Number 2, it works on the kidneys, specifically the collecting duct. And the third was our sweat glands. Remember, our sweat glands respond to acetylcholine. And so you get sympathetic innervation of the sweat glands. ADH comes in and inactivates the sweat glands. That makes sense because that's our other way of losing water. The last of them, of a hormone, is called atrial natriuretic peptide. This is a hormone that we haven't quite talked about, but this is a hormone that's secreted by the atria. Why is it important? Well, it's a diuretic. So the stretching of the atria due to increased blood flow into, from the vena cavas into the right atria is going to cause lowering of blood pressure. So the atrial natriuretic peptide, or ANP, is released by the atrial cells. We have stretch receptors in there. As the right atria stretches out, it must mean we've got high blood pressure because the atria that is stretching out. Therefore, that release of ANP is going to decrease blood pressure as a potent vasodilator. So number 1, lower blood pressure. Number 2, reduce blood volume. And how does that work? Well, it's the exact opposite of the other enzymes that we've talked about, aldosterone. ADH. And then aldosterone and ADH. So These are the antagonist relationship waves. So looking at that, as I mentioned earlier in our prior slide, where I talked about the difference between systemic versus pulmonary circuits and the response to low O2. Again, low O2 is also known as hypoxia. Hypoxia, related to low O2. Hypoxia is going to result in systemic blood vessels dilating, opening up the blood vessels, as opposed to pulmonary blood vessels, which will constrict in order to divert that blood over to the areas that are more oxygenated. Again, we'll revisit that when we get into our respiratory lecture. So moving at that, let's take a little change of pace and start to tie in what we're going to be learning today in our lab, looking at circulation. So circulation, when we look at peripheral circulation, we want to measure blood pressure, which is an indication of how much blood is flowing through the heart. And that's going to give us our systolic pressure as well as our diastolic pressures, knowing that pressures resemble the force of, or the pressure of blood being exerted during ventricular systole and during ventricular diastole when the heart is at rest. So we're going to be able to measure these pulses. And just kind of as a side note, how do we really I guess we can't directly measure, but another indirect measure, which is a better clinical tool for determining how much blood flows to the heart or blood flows out of the heart. That's where you do an echocardiogram. It's basically ultrasound into that area. They can measure the diameter of the vessels of the aorta, and they can see the spurts of blood that's flowing through during systole and diastole. And from there, they can determine how much blood flow, which is a better accurate measure as opposed to inferring blood flow through blood pressure. But blood pressure is the easiest clinical tool. It's a thing that you do for vitals when a patient presents at a clinic. So in this case, what are we doing? We're measuring the differences in pressure, systolic and diastolic. But at the same time, we can also derive the heart rate. And we do that by just measuring the pulse. And what exactly is the pulse? When you look at the blood that flows out of the aorta, that's where we're going to feel the strongest pulse. So if you have a way of sticking your hands into somebody's aorta, you'll feel the contraction, or rather the pulse of blood flowing through. And the further you move away, you'll notice that pressure wave is a little bit smaller. If you were to measure somebody's pulse in their arm versus measuring their pulse by their foot, you'll notice that the pulse in the arm is stronger. And that pulse, again, is the pressure waves, the systolic and diastolic waves that are moving all the way through down our elastic and distributing arteries. So with that, we can derive what our heart rate is by just measuring the pulse. So how do you do that? Well, you have your ways of doing it. Basically, you just count the number of beats that you're feeling whenever you're palpating the wrist or the foot, and that will give you our heart rate. Side note, why do we not want to measure heart rate by doing this? You probably see people measure their heart rates by measuring the carotid artery, right? You will feel their pulse, and they can feel it, and they'll measure it from there. Why do we not always do that? It's not the most appropriate clinical tool. Mainly because we have baroreceptors in there. And those baroreceptors in the carotid sinus, if you start to increase pressure in that area, that's going to decrease blood pressure. And therefore, decreasing blood pressure is going to decrease heart rate. So it's not our most accurate. So you want to do it in an area that's away from those baroreceptors, specifically by the wrist. Kind of the reason why, I guess, one of the reasons why you don't see nurses come in and just jab their finger right into somebody's throat to measure their heart rate. It's a little invasive, but not, again, not the most appropriate. So how do we measure our blood pressures? Well, you guys are going to learn how we actually do it, the mechanisms to do it, or rather the procedure for measuring blood pressure, if you don't already know. But this is going to explain the mechanism behind measuring circulation. It's one thing to know how to do blood pressures, but it's another thing to understand why or how we derive blood pressures. Yes?
So like, right, we have patients that have like
What is it again?
They're like LVAD machines, like they have like, either have a total artificial heart, or they have like a machine that pumps like the left ventricle move, you know?
Yeah,
and, like, pumps it through the aorta and stuff, but they have no pulse. They're alive, they're walking.
So this is continuous blood flow, right?
Yeah.
I've read about these. Really interesting thing about them. They're I hope we're talking about the same thing, but
There's two kinds. There's some where they just have like total artificial heart. They have like a backpack that like just makes noise and it's just pumping.
Yeah.
The tube.
Yeah.
You see them walking around, and the other ones just have a little device where it just helps the left side of the heart.
Yeah.
Pump.
I think we might be talking about the same thing, but I remember reading years ago about a guy who was the first, this is years ago, he was the first one to be tested with a continuous device. And so the way blood flows through the aorta is through spurts, again, systolic pressures above diastolic pressures. So if you ever watch any old movies and like somebody's neck gets cut and you see blood squirting out like that, that's exactly how blood flow works. You just get spurts over and over again, and those spurts are representative of heart rate. Now in those continuous devices, instead what they're doing is just a device that just generates the same output as cardiac output. It's like literally turning on a faucet and allowing continual flow of blood. You can still maintain blood pressure, but you're not getting the systolic versus diastolic. If you were to measure their pressures in their arteries, there is no pulse. Why? Because you don't have the systolic waves. So check to see if those are the same people, because I don't remember too many people getting this continuous thing. And I think when I read it, they were doing research on it, thinking.
It's kind of like when they're waiting to get a heart transplant. So keep them alive while they're waiting for the heart.
Yeah, exactly. That's what they use is the machine that just basically allows continuous blood flow without using the pulse. So I don't remember, again, I read this years ago. They were speculating, is there really any reason for those systolic waves? Is it really necessary? Because by the time it makes its way to the capillaries, we lose the systolic versus diastolic waves. And at that point, all we really need is to make sure that we have enough blood pressure, enough hydrostatic pressure to enable fluid movement. So if you do find out, let me know the name of the machine. I can look it up. It'd be interesting.
LVAD, like an LVAD.
Okay. Left ventricular assistance device.
Yeah, left ventricular.
Okay. So with that, thank you for sharing. But in normal people that have normal hearts, you have the blood pressure that is measured. Here, what you would normally see, again, 80 representing our diastolic pressures, 120 measuring the systolic peak that takes place during ventricular systole. So what we'd expect the pressures to look like would be this. These pressures. And as I mentioned earlier, you see where we spend most of the time. We spend most of the time in diastole, while a third of the time we're in systole. So what we want to do to measure pressures, we want to measure them specifically, and I'll just jump to the next slide real quick. We want to measure right within the brachial artery, which is close to the aorta. Same level with gravity. We want to be able to measure this. If we were to measure blood pressures in the leg, somehow if you were able to get a blood pressure down to the leg and measure it there, that wouldn't be the most accurate measure. Why? Because we have the effect of gravity. We have gravity pulling down on blood. Therefore, blood pressures would be lower in the foot. And if you were to get a blood pressure around somebody's neck, which I would not advise you guys to do, you would measure blood pressure over there would be a little bit lower than that of the heart. So we want to measure somewhere close to the heart, which the brachial artery is the best area. And what we do is we hyperinflate the cuff. We're going to bring that pressure well above where we expect to find systolic pressures. So we inflate it to about, and typically you bring it up to about 180, about to 200. And once you get it up there, we're going to now occlude or block the brachial artery. So if I can just draw the brachial artery, and here's our cuff. The brachial artery is going to be completely occluded, completely blocked, preventing any blood flow through that area. At the same time, you're also going to have a stethoscope, and you're going to listen for any sounds downstream from the cuff. So you can place your stethoscope right below the brachial artery and listen for any sounds. Any sounds that you hear is blood moving. Well, specifically, it's going to be the sound of turbulence. So where do we start to see turbulence? once we get to this point right here, we're going to start to lower that blood pressure, or lower that cuff. And as we lower the pressure in that cuff, bring it down, bring it down, bring it down. By the time we get to about systolic pressures, we open up, there's less pressure, there's about a little less pressure in the cuff than there is systolic pressure. In other words, systolic pressure, the pressure of that blood is just enough to be able to force blood through the most smallest opening because the pressure on the cuff is less. And therefore, blood starts squirting out just a little bit through. You get a little bit of blood squirting out, and that's going to create sounds that you can hear. And these sounds are called Korotkoff sounds. They're the sound of blood turbulence as it flows through the brachial artery. So now you start hearing sounds. And you're going to see that the sounds are going to sound different as you move from 120, from systolic, all the way to diastolic. And that means that during these pressures, in between 120 over 80, you still have that pressure on the cuff. And that pressure on the cuff is still going to squeeze that brachial artery and still cause those turbulent sounds, which you're going to continually hear, up to the point that we get to the diastolic pressures. So by the time we get just below the diastolic pressure, the pressure in the artery is higher, well higher than any of that exerted by the cuff. In other words, the cuff does not occlude the brachial artery anymore. And at any point, as long as blood is flowing through optimally, we get laminar flow. That means blood flows smoothly through the vessel, and therefore no sounds will be heard. So everything from this point to this point is going to cause turbulence. So the emergence of the first sounds that we hear, up to the point of the absence of any sounds, is going to be representative of systolic pressures and diastolic pressures. So that's how it's going to work. So with that, we can get our measures of our systolic pressure versus diastolic pressure. And one of the things that we want to be able to see is being able to diagnose hypertension versus hypotension. And hypertension is basically a high blood pressure. It's a very common disorder that you would see. And it lends itself to many other diseases that can come out of it. So hypertension is not necessarily a disease per se, but it's a symptom or a disorder that can lend itself to other types of diseases that can take place as well. Because as you start to see, it'll start to cause a whole host of other things where you have edema as an issue. We can start to see the emergence of atherosclerotic vascular disease. If you have high blood pressure, right? Think about high blood pressure. A high diastolic pressure means that the left ventricle has to pump higher than, let's say, 90 or even 100 diastolic pressure to be able to push blood out of the heart. So that's like saying that's pressure being put on the left ventricle that has to, additional pressure that has to be overcome in order to eject blood out of the heart. So now you've got your heart working overtime to pump against that increased systemic resistance. And that could lend itself to other diseases like congestive heart failure. That also imposes a lot of pressure on the kidneys as well. And therefore the kidney function starts to decrease over time. These are important. So where do we start to see where abnormal blood pressure takes place in the case of hypertension? Well, the way it's clinically set right now is normal is 120 over 80, and in women it's actually lower, which you'll be able to see on the next couple slides. Pre-hypertension has been labeled as 120 over 139, 120 to 139 over 80 to 89. Stage 1 hypertension, above 140. Stage 2 of that above 160 for systolic. So these are important to take a look at somebody's blood pressure. We want to bring that back to normal. So all this was derived. How did we come up with these numbers? It's not like we just threw some numbers up and just said, hey, let's just call this hypertension. They've actually been able to perform a study, and I think I talked about this before. It's called a Framingham study, in which back in 1948 is when they started to measure the life expectancy and mortality and all the health measures of people in Framingham, Massachusetts. And I forget how many people were there at the time. but they wanted to follow all the people from Framingham and not follow just that first generation, but the second generation and third generation. But I think it's one of the things that you have to, I guess, as a citizen of Framingham, Massachusetts, you're part of this study where they'll send you questionnaires about your diet, questionnaires about your history. They want to know all about you because that's going to tell us later down the line, what are these people, what could they possibly have died of? So with that, they were able to see people that had hypertension, or at least higher systolic and diastolic pressures. They found that these were the people that were more susceptible to heart diseases, heart failure, kidney disease. And with that, they were able to not only look at people with their systolic and diastolic pressures, they also looked at age. So one of the things about the Framingham study, and I worked with a professor at UCLA that looked at these numbers, and he found that the older we got, the higher their blood pressures came. So about people in their 40s, 30s, and 40s found that they were so-called pre-hypertensive. And so he felt that age is just a normal factor as to why blood pressure would come up. So why was that important? Why did researchers at this time say, well, this is pre-hypertension, you should start probably taking medications to bring it down? He felt that it might have been a pharmaceutical push to start labeling people that are pre-hypertensive to get them on drugs, to get them on hypertensive drugs, antihypertensive drugs, to bring their blood pressures down when it could have been somewhat normal. But nonetheless, it's one guy versus all the people that were involved in this study, which is fairly huge. It still currently drives the reason for a lot of clinical decisions that are made today.
Why is it bad to do exercise if you have high hypertension?
Because what we're doing at that point, when you already have high blood pressure, when you start exercise, you're already raising blood pressure as is.
Oh, so you're doubling it.
Yeah, so typically what happens with exercise is you would actually expect your blood pressure to rise a little bit, and then it should actually normalize. People like to think that during exercise, your blood pressure raises really high. And that is true to a certain degree, depending on the type of exercise, depending on also the type of exercise, whether you're, and the intensity of it, whether you're doing like resistance training or you're doing cardiovascular exercise. Cardiovascular exercise, your blood pressure stays roughly the same. It goes up a little bit, but we still maintain normal blood pressure. Now resistance training, actually you will see blood pressures rise quite a bit. So anybody that's doing some heavy squats, your blood pressures are raising up to about 300. But obviously you're not maintaining a squat for that long. It's not like you're doing it for half a day or anything like that. But nonetheless, that's why it might be an issue, because your blood pressures are raising high and then they're coming back low and higher and lower. And people that do have some form of heart disease of some kind, they just want to be monitored. We're not telling them not to do exercise. It's just be aware that you could faint or you could have any issues that come up. So typically those people you want to monitor. And even before that, you want to advise people that are pre-hypertensive to start getting on some sort of exercise regimen. You typically tell people, lose weight, do more exercise, and that'll usually bring it down quite a bit. And that's something that you also see with people that do exercise quite a bit. Their blood pressures will drop. And that's because the heart's much more efficient, being able to pump blood out, and that will normalize blood pressure. So with that, the other thing that we'll look at is hypotension, where this is a lower blood pressure. And in hypotensive people, that any women here with low blood pressure? Yeah, so when you probably go to the doctors, they tell you your blood pressure is kind of low. Are you okay? Do you feel dizzy? Do you feel dizzy? And if you just report that you're normal, okay, then they can just accept this is your baseline. We expect your blood pressure to just be that, and if we see it drop any lower, then it might be a cause for concern. If it goes up a little higher, then I guess that would be more about normal. But nonetheless, if you're not reporting any symptoms of any kind, then I guess you're okay. So typically women, especially smaller women, or not smaller, but height deficient. I was trying to think if it's politically correct to say smaller women, but nonetheless, if women have a tendency to have lower blood pressure. As long as that's okay, and you don't have any symptoms, you should be fine. But normally, hypotension, low blood pressure, clinical hypotension is going to be a cause for concern, because that's going to, again, relate to perfusion, blood flow, and fluid exchange with our organs. So we want to make sure that those organs are getting the right amount of glucose and O2 and removing CO2 in order to make sure that that tissue is still functioning. Okay? We want to make sure that, that there's enough blood flow to those areas to contribute to maintaining survivability. So with that, there's some theories behind why women have lower blood pressure, and there's some theories behind estrogen being a factor too, that estrogen has a way of bringing down blood pressure, because they've done studies on women that are postmenopausal, where estrogen drops quite a bit, and they found that their blood pressure comes back to normal after menopause. And another thing too is they also look at the effect of testosterone. Testosterone has a tendency to raise blood pressure. So maybe that could be the reason why it's normal to have low blood pressure, but testosterone brings that back up. The last concept that we'll talk about in the next couple slides is the concept of shock. So all we've been talking about that have been leading up to this point is the extreme version of where now we have extremely low blood pressure that would result in less perfusion of our tissue beds. And of those, again, life-threatening, because due to that low blood perfusion, results in not enough oxygen to those tissues. And obviously that can be a cause for concern, because ischemia is, or damage due to low O2 is a concern. So we have different ways in which we would have extreme blood pressure drop, of which we have 4 types. And that first is hypovolemic, so a drastic drop in blood volume. So hypo being low, volemic being volume. We have a way of decreasing our blood volume. How do we do that? Blood loss. So somebody who's been in a motor vehicle collision of some sort can have loss of blood, and that causes hypovolemic shock. So a decrease in blood pressure can cause that. Dehydration is another way. Loss of fluid. Okay? Loss of fluid means loss of blood volume. Cardiogenic shock is related specifically to the heart. And it's all related to poor heart function. How so? Well, ischemia of the heart, or myocardial infarction, which is heart attack, can contribute to poor left ventricle ejection of blood. So LVEF, left ventricular ejection fraction. Looking at congestive heart failure is another one. Obstructive shock basically means that there's some obstruction of some sort to blood flow, whether that happens in the heart or it happens in the vessels. Typically that could be pericarditis is another way. Again, an inflammation of the pericardial layer over the heart. Any pericarditis would come in and create excess fluid that prevents the heart from fully expanding up to the limits of the pericardium. So because now that heart can't expand all the way, now that's going to be decreased blood flow, so it's an obstruction in that area. A pulmonary embolism can come in and interfere with the amount of blood flow back into the heart. So that interferes with the pulmonary circuit. Another way is stenosis, aortic stenosis. This is blood flow out the aorta. And if you see narrowing of the aorta, again, obstruction of blood flow out into the systemic circuit. The last of these is distributive shock. Distributive shock is extreme vasodilation. And a good example of this is anaphylactic shock. You get somebody who has an allergy to peanuts, and you're sitting there munching away at peanuts right next to them, and all of a sudden that person reports feeling their throat close up, and they're having this response where they can't breathe, and all of a sudden they pass out. What happens is they have a massive allergic response. It's a huge histamine response. Histamine is a vasodilator, and take that with a systemic response, and all of a sudden blood pressure drops dramatically, again affecting perfusion of the critical tissues. So what do they do in those cases? they might have an EpiPen, which I don't know if I know EpiPens went up in price, like ridiculous. I don't know if it went back down or anything like that, but nonetheless, there are a lot of people out there that can experience anaphylactic shock and need to have an EpiPen in case of anaphylaxis. So I've never really understood why pharmaceutical companies could raise the price of something like that, for especially in the case where this could cause death, but that's another topic. If you're at UCLA, you've probably seen the banners for sepsis. Take a look at sepsis. Why is sepsis important? This is an infection of the blood. Infection of the blood can cause, again, extreme vasodilation and can cause immediate death if not identified. So at UCLA, they've got a bunch of factors, a lot of clinical metrics that they're looking at to see cases of sepsis. And obviously, if there is an infection, we want to prevent that infection to anybody else, because it does cause quite a bit of number of deaths at the hospital. So that's another thing to think about is, and not even just sepsis, all the other diseases at hospitals too. It's crazy when you walk around hospitals and I remember when I first worked there, I wondered why they kept using stuff on their hands and wiping things down, and I thought, it's a little extreme. But no, there's a bunch of diseases at a hospital, MRSA, C. diff, there's a bunch of them out there. And these are cases where people can come in just for a simple procedure and then walk out with something where they have an antibiotic resistant strain of some sort and end up dying or something else.
That they, what was it, in the last couple of years, there was one hospital that caused 4 deaths because something wasn't properly cleaned.
What was the Huntington Hospital with the GI scopes?
That was UCLA.
Yeah. Oh, Huntington had that same issue.
Yeah, the endoscopes.
Yeah.
These are big things.
Yes,
Yeah. If any of you guys are ever interested, epidemiology is always a cool profession. And those are the ones that study diseases. And epidemiologists are the ones that are we actually have a small team at UCLA, but they're infection control people. So they like to look at cases and find positive cases of any diseases, and they need to go around. They're investigators, and they try and trace where the origin of that bacteria comes from, or a virus or anything like that. So they take cases and they go through and they interview and they go case by case, look at who's met with who. Has anybody ever watched Outbreak or Contagion or any of those movies? Contagion was a really good one. I think that was a more recent one where you had, they were epidemiologists that want to study the diseases that came on board. Same people that also studied Ebola, and they trace where people have been exposed to and the pathways that have led to and all that. In fact, epidemiologists also get, if you ever work on a cruise line, they could hire you as an epidemiologist, because if there's ever a case of food poisoning, you got the perfect case. You've got, let's say, I don't know how many people on a cruise, 15,000 people, 1,500 people, 2,000, but you've got a closed scenario. You've got the same amount of food, and anybody that gets food poisoning, you got to go around and interview people and find out what did you eat at what time, what day, were you exposed to anything else, and they have to go around and interview everybody and take all that information and see what patterns do we see here. It was all the potato salad at this time that was served by this person, and it all comes down to
Didn't wash their hands.
something just washing their hands. Chipotle was a good example of that. There's only 2 places where that took place. I don't remember where, but it all ties down to you gotta wash your hands.
Didn't UCLA get in trouble for that too? Not washing hands, the bronchoscopes?
That's what we were talking about. There was these GI tubes that they were using, endoscopes that we're using, and the question afterwards became whether it was related to the company that supplied them, or was it practices at UCLA at the time. I don't know whatever came of it, but the big thing, of course, that came out of it was lawsuits. So with that, I don't want to go into too much detail about that, but I remember in grad school when I took epidemiology, I was just like, I had kind of a heart for it, and I'm like, I wish I had gone into that because it just sounds so interesting. Now looking at that, basically all of shock we already saw with hypotension or severe hypotension, we want to be able to respond accordingly by increasing sympathetic output to restore blood pressure. So we want, in essence, when it comes down to, in cases of shock, we want to be able to provide adequate blood flow to our critical organs. So that's why some of the symptoms that we'll be able to see, all the other mechanisms that we saw to auto-regulate to bring blood flow back by restoring by increasing cardiac output and increasing venous return are all different ways to maintain blood pressure. All of our renal pathways that are enacted in order to raise blood pressure work back up. This you'll see is, and I might need to change these a little bit, but basically what it comes down to is shock. With the initial drop in blood pressure, you'll see all the other responses that come back up. The first line, heart rate and contractility force increase. You'll see these are heart responses. Vasoconstriction, vasodilation are vessels. ADH and renin and aldosterone are all endocrine. ANP, again, cardiac, but still considered endocrine. So all of these are going to be systemic responses all across the board to make sure that we can maintain blood pressure. And as some of the organs fail, it's not uncommon for seeing people that are in shock. And when you get one organ to fail, if you get your kidneys to fail, you've lost a good mechanism, actually 3 good mechanisms in maintaining blood pressure. Kidneys start to fail, then you'll start to see other mechanisms start to fail as well. So with that, it's not uncommon to see at end of life, at the point of end of life for somebody, you'll see multiple organ failure. And then all of these right here basically point out what medications are used. Epinephrine is typically used to raise blood pressure back up, and then organ failure afterwards if that doesn't respond. So looking at the common symptoms of shock, you should now be able to explain some of the symptoms that you would see if they were ever presented in a clinical arena. So pale, cool, clammy skin. Why would it look pale? Recall of fluids, right? You get fluid being pulled away from the skin, it's going to look pale. It's going to be cool. Why? Again, because vasoconstriction is, again, going to redirect that blood away from the tissue. Clammy. Why is it clammy? Well, these are the sympathetic effect. A bunch of catecholamines. You've got a bunch of epinephrine flowing through you. And that's going to override and cause it to be a little sweaty. And I guess the question, if any of you are wondering why sweating, well, ADH should come off and turn off sweating, but the amount of epinephrine that's flowing through your system at that point in time will cause more sweating than that that's being inhibited by ADH. Nausea and vomiting, typically due to low sodium, hyponatremia. Tachycardia should be self-explanatory. Weak pulse, again, self-explanatory. Increased respiration is due to all the catecholamines, again, epinephrine and norepinephrine flowing through the circulatory system. Decreased cardiac output, again, self-explanatory. Thirst is the increase in ADH. If you have increased ADH, increased antidiuretic hormone, that's going to drive the thirst centers in the medulla oblongata. You need to take in more water, so it's not uncommon that someone's tongue will look super dry. Dilated pupils, again, a sympathetic response onto the radial muscles of the eye, causing dilation of the pupils. Cyanosis of the lips and nail beds, another something that they're looking for. If you have people that present in a clinic that have pulmonary diseases, first thing they want to take a look at is their nail beds. Is it purple? That's going to give you an indication that there is vasoconstrictions on the nail beds. Something that's also interesting, especially with people with COPD, look at the formation of the nail. It starts to create this sort of curved look to them.
Digital clubbing.
There you go, perfect. That's exactly what you would typically see. The less blood flow to that area causes malformation of the nail bed. So these are things that are good indication. You can really start to see, based on the symptoms, what they could possibly be. So I know that's a lot of information there. With that, we've got ideally another hour that I'd like to